Vinitha will start, sir.
Yes,
Okay.
sir, I'll start, sir.
Go ahead.
The case scenario given to me was a 65-year-old male, chronic smoker, smoking 2 packs of cigarette per day for the past 45 years, with history of cough with expectoration, was admitted to ICU for 3 times in the last 3 years, has multiple symptomatic gallstones, posted for lap cholecystectomy. Presenting complaints, uh, uh, there will be pain. I'll ask for complaints of pain in the right upper portion of the abdomen, whether it is associated with nausea, vomiting, or anything, and complaints of cough with expectoration for the past 3 years. History of presenting illness. I will ask about the complaints of pain in the right abdomen, right upper abdomen. About the onset, whether it is sudden or insidious, duration, frequency, whether it is radiating to some other place, regarding the intensity, whether it is decreasing or increasing, regarding the character and association with nausea, vomiting, and fever. And regarding the complaints of cough with expectoration, I will ask about the duration, whether it is continuous or intermittent, associated with sputum or not, color of the sputum, smell, quantity, and whether it is blood tinged or not. See, smell, and postural variation cough. Any cough present right now, whether the symptoms have decreased with treatment. I will ask about the history of breathlessness on exertion, whether patient is able to climb to a flight of stairs without breathlessness, history of nocturnal awakening with breathlessness, or breathlessness with on lying down. And I will ask regarding the history of weight loss, loss of appetite, and evening rise of temperature. And I will also ask regarding the history of palpitation, swelling of the lower limbs and chest pain. Past history, that is history of hospitalization ICU thrice in the last 3 years. I will ask whether he was on oxygen support or any other ventilatory support. When was the last exacerbation, and associated comorbidities like history of diabetes, hypertension, tuberculosis, childhood breathlessness, food allergy, jaundice, epilepsy, coronary artery disease, and CDA, and history of previous anesthetic exposure, history of previous surgery. Treatment history, regarding whether the patient is on any inhaler or taking any oral medications, regarding the duration, frequency. Family history, I will ask about the similar complaints in the family. Personal history, the patient is a known smoker. I will inquire about the number of years of smoking. Is he still smoking? And when did he last smoke? Scenario given was patient was a smoker for the past 45 years, 2 packs per day. So the pack years is 90 pack years, and smoking index is 1800, which indicates he is a heavy smoker. And I will ask about the history of alcoholism and diet habits, bowel and bladder, and sleep habits. General examination, I will examine about the consciousness, orientation, time, place, and person, whether the patient is alert, built, whether he is well built or thin, and nourishment and hydration status. I will measure the height, weight, BMI, and look for pallor, itchiness, cyanosis, clubbing, lymphadenopathy, and fetal edema. And vitals, heart rate, blood pressure, respiratory rate, and use of accessory muscles, temperature, and room air saturation, and elevation of jugular venous pulses. Airway examination, I will examine the mouth opening, mallamati grading, thyrometric distance, neck movement, upper lip bulges, and the TM joint mobility. And then spine alignment, spine alignment, and scoliosis. Systemic examination, abdomen examination, inspection whether the abdomen moves with respiration, any distension, scars or sinuses, dilated veins, visible pulsation or peristalsis, hernial orifice and external genitalia. Palpation, I will palpate for tenderness, guarding, and rigidity. Any tender hepatosplenomegaly. Auscultation, I will auscultate for bowel sounds. Respiratory system, upper respiratory tract, including the nose, throat. And on inspection, I will see whether the trachea is in midline, shape of the chest, whether it is barrel shaped, supraclavicular hollowing, infraclavicular flattening or drooping of shoulders, bilateral chest movements, decreased or increased, normal, respiratory rate, use of accessory muscles, dilated veins and visible pulsations. In palpation, I will see for local increase in temperature, chest wall tenderness, confirm the position of the trachea, chest expansion at the level of nipple, anteroposterior diameter and transverse diameter, and chest movements and vocal parameters bilaterally. Percussion, I will look for the presence of resonant note over all areas, and cardiac wellness. In auscultation, breathless breath sounds, any wheeze or fluctuations present. Cardiovascular system inspection. I will inspect the precordium, dilated veins and veins for scars. And in palpation, I will palpate the apex bit and see whether there is parasternal palpable P2 and 3. And auscultation, I will auscultate the hormones. CNS, higher middle function, renal nerves, motor system, and sensory. So summary, is a 65-year-old male who is a chronic smoker with a smoking index of 1,800, with a history of cough with expectoration, is now having symptomatic gallstones post-record laparoscopic cholecystectomy.
Okay. So this description you have given like examining a real patient, right?
Yes,
Okay. Supposing this case scenario is given instead of the patient, how will you analyze this case? They just give you in a paper, this is the case scenario as I have given. That is the way the examination is conducted with the case scenario alone, without the real patient, then how to go about?
So probably this looks like a case of chronic bronchitis.
Okay. So did you describe anything about the general examination appearance of the patient?
It's a built and nourishment. Color blue board.
So it's
Cyanos.
very important whenever you from the scenario or the case history given, we can come to a rough diagnosis or a probable diagnosis, isn't it? He's a chronic smoker. He has been admitted with breathlessness 3 times in the last 3 years. All these clues give you that it is to be only a classical description of a chronic bronchitis patient because of smoking history and 3 times admission in the last 3 years in ICU with breathlessness requiring emergency treatment. Because cardiac patients will have a continuous problem throughout the year. Whereas the chronic bronchitis in the early stages until it becomes very serious and very chronic, really chronic and persistent, they will initially have periodic admissions, usually seasonal in the winter months when the climate is very cold. That is the time they fall sick and then they first develop chronic cough, then it becomes breathlessness, then they bring out a lot of sputum coughing out, and they desaturate and they are rushed to the hospital and then admitted in ICU. And this problem occurs 3 consecutive years. That is the classical description of chronic bronchitis, which is one component of the chronic obstructive pulmonary disease. Okay. So if that is the case, then you have to give a correct description of the patient when you do the general examination. We normally start with patient is well built, ill built, or looking malnourished, or appropriate for the age and the height and weight. Is looking the build is okay. So that is the description with which we start the patient, isn't it? So that time you can include their appearance as little bulky people looking, having a dullish or a slightly cyanotic color, both in the lips and in the fingertips. If that description is present actually because of the chronic bronchitis, then it is better to include the description so that can clinch the diagnosis at that point itself. Okay. So, okay. Now you have finished all the classical descriptions of this patient. Now, how are you going to manage this patient? Supposing the examiner asks you, okay, I accept with your diagnosis of chronic bronchitis, which is a component of chronic obstructive pulmonary disease. And this patient requires a cholecystectomy because he has got gallstones, and it is planned to be done as a laparoscopic procedure and not as an open procedure. So if this is the problem and you get a real patient like this in your practice in future, how are you going to manage?
So first I will ask for a few investigations, then risk stratify, optimize, and then proceed for surgery, sir. Investigation, apart from routine investigations like complete blood count to rule out anemia or presence of active infection, as indicated by increase in the total count. And I will ask for renal function test, serum albumin to see the nutrition status, I will ask for ECG and echo to rule out right ventricular hypertrophy or right ventricular failure, and chest X-ray to confirm the diagnosis. I will see the room at saturation and order for blood arterial blood test to see the PaO2 and PCO2 levels. And
What
the
do you expect in
acid
the arterial blood test investigation? Can you enumerate what is the reason for you asking for this investigation and what findings you expect in them with this history and your diagnosis of chronic bronchitis?
So these patients will be hypoxic. PaO2 is decreased, usually less than 80, 60 to 80, and PCO2 will be increased.
So they will be in type X. You expect them to be in type 2 respiratory failure. That will be a better answer than saying, or you can say they will be hypoxic and hypercarbic. Okay? So instead of saying their PO2 will be decreased, PCO2 will be increased, use the correct terminology. I expect them to be hypoxic and hypercarbic or in type 2 respiratory failure. Okay? So that is what you, okay, right. What do you expect in the X-ray test, ECG, echo, and all these things?
So there will be flattened diaphragm, tubular heart, the intercostal space will be widened, and there will
Chronic
be
bronchitis, do you get a tubular heart?
usually in emphysema.
It is if it is emphysema, you are right. But if it is a chronic bronchitis,
there is increased bronchovascular markings because of hypoxia. There will be pulmonary artery, increased pulmonary artery pressures. Increased bronchovascular markings and flattened diaphragm.
what will happen to the right heart, right ventricle?
Right ventricular hypertrophy can be present.
So what will it produce in the cardiac shadow? In the right ventricle, the left border of the heart is made by what? In the X-ray chest, when you describe the cardiac shadow, you say about the right border and left border of the heart, isn't it? What
right border, right
mostly right
atrium and
part of the right ventricle.
And part of right ventricle.
Whereas left border is mostly left ventricle is more posterior, isn't it? So it will be
left.
So it will look like a cardiomegaly. Okay. So X-ray chest also you have to see whether the cardiac size is enlarged. That because of the cardiomegaly, because of the right. Why you have to look specifically for right heart, the right ventricular enlargement?
So these patients are chronically hypoxic, so there will be pulmonary hypoxic pulmonary vasoconstriction, leading to increase in pulmonary vascular resistance and pulmonary hypertension, leading to right ventricular hypertrophy and right ventricular failure, causing cough pulmonary.
So we should not concentrate only on the left ventricular function, but we should concentrate on the right ventricular function also. And right ventricular size is very, very important because the pulmonary circulation gets affected in chronic pulmonary obstructive disease. Okay, so you have to give more importance and examine the right side of the heart more in detail so that you don't miss that, because that is one silent thing which will easily kill these patients. Okay, right. So in the X-ray you find what will you find in the echo? Why you want an echocardiogram for this patient?
So to rule out any regional wall motion abnormality, left ventricular ejection fraction, and to see the mean pulmonary artery pressure, right ventricular systolic pressures. Whether there is RV failure.
What is TAPSE? You heard of that? TAPSE, TAPSE. What is the importance of this TAPSE? Anybody else? Any other exam going or any non-exam goings also can participate and answer this. Pratik Shukla, are you there?
Good evening, sir.
Good evening. What is TAPSA? TAPSA in echo. What is its importance?
Sir, tricuspid annular plane systolic
Excursion.
excursion, sir.
What is that? What is the importance of that? What do you
Sir,
understand by that?
sir, right-sided heart ejection fraction means.
RV systolic function,
RV.
tricuspid.
Yeah, good. Tell me, RV systolic function. What happens when they describe that? What is the normal value?
Less than 20.
See, whenever the RV contracts, mutually, earlier we were concentrating, most of the cardiologists and the sonologists who do echocardiographic studies, they were concentrating only on the left ventricular function, describing about the left ventricular end diastolic volume, systolic volume, and for calculating the ejection fraction from there to assess the systolic function of the left ventricle. So far, we were not concentrating for a long time on the right ventricular function. So the recent echocardiographic improvements have included the right ventricular function also, because majority of the patients have poor right ventricular function. So naturally, if the right ventricle is not able to pump adequate blood into the pulmonary circulation, the left ventricular filling is going to get decreased, and the left ventricular output is also going to get affected. So now they concentrate more on the right ventricular function also. So they describe a parameter called TAPSA, TAPSA, which is tricuspid annulus plane systolic excursion. Wherein what happens when the right ventricle contracts, the lower part of the right ventricle comes closer to the tricuspid valve because of the contraction of the right ventricular musculature. The lower part or the apical portion of the right ventricle comes closer to the tricuspid annulus because of the contraction. Okay, and this should be normally 16 millimeter, 1.6 centimeter or 16 millimeter should be the decrease in that, or nearing about the lower part of the right ventricle to the tricuspid area. So if that is less than that, that means the contractility is not good. So this should move at least 16 millimeter from the lower part towards the annulus, so that the muscle is contracting very well. And this gives a vertical contraction distance. So they have included another parameter called right ventricular fractional coverage area, RVFCA, which measures the transverse contraction of the right ventricle also. So these two parameters are now included in most of the echo studies to find out the right ventricular output or the functioning ability of the right ventricle. Okay, so that is a very important parameter which you have to look for in cases of COPD. Unlike the other cases where we are more worried about the systemic circulation and systemic function, that is mainly left ventricular function. In all COPD cases, you have to look for these two parameters in the echocardiographic report, which gives you an idea about the right ventricular function, because these patients in advanced stages, they suffer from more of right ventricular failure rather than left ventricular failure. Okay, that is the problem that is happening. Why do you say about regional wall motion abnormality? In these patients, will they get any regional wall motion abnormality? Especially the left ventricular septum or the left ventricular anterior wall, will they get any problem there?
No, sir.
No. Why?
Because of there can be
What
ischemic
this
heart
chronic
disease.
smoking, what will it do to the vessels?
There will be constriction of increased coronary vascular resistance, so there is
They
decreased.
can produce both type 1 and type 2 vessel changes. Okay, type 1 is mainly atherosclerotic. We saw in the other class when we talked about myocardial ischemic heart disease in discussion, we said there are two types of myocardial infarction or ischemia. One is type 1, another is type 2. In type 1, it is the classical atheromatous plaque which becomes unstable, gets ruptured and forms the thrombus, and there is a complete occlusion happening, which is the most of the time the pathophysiology in ischemic heart disease or the coronary artery disease patients. Whereas in the type 2, there is a narrowing because of partial coverage of the atherosclerotic plaque, but there is no disruption, there is no thrombus. The other important factor is the spasm or the constriction of the coronary vessels, which also decreases the blood flow. And because it's a spasm, there is a chance that it will get relieved and the restoration of the blood supply will be happening after some time. That is where your NTG and the other drugs will help. But if it is a plaque rupture with a thrombus formation, we don't normally encourage the patient to or treat the patient with NTG because we find that it's not of any use because it's a mechanical obstruction produced by the plaque rupture and the thrombus formation. So in that situation, NTG is of no use. Earlier, during our student days, whenever a patient comes with chest pain and if you find ST elevation or depression in any of the leads and you suspect myocardial infarction, the immediate treatment is to start NTG. But nowadays, you will find the majority of the cardiologists either do thrombolysis or take the patient for PCI for type 1. It is only if you suspect type 2, you have to start them on NTG. Otherwise, NTG is not a routine for any coronary artery patient coming with anginal pain nowadays. Okay. So this smoking can produce either an accelerated atherosclerosis and a type 1 ischemia, or it can produce a spasm, and because of chronic catecholamine release can produce a spasm and type 2 ischemia also. Okay, but by ECG or echo, it is very difficult to find out unless he has suffered a small area of infarction and that area becomes hypokinetic, then you can find regional wall motion abnormality. Otherwise, it is very difficult to find out that, but you may find evidence of ST changes because of ischemia in the ECG. Okay, so that is the reason why we want all these investigations to be done. And what are they may ask you questions on the harmful effects of smoking. So, what are the harmful effects of smoking? This patient has been smoking 2 packets of 20 cigarettes a day. That means 40 cigarettes a day he has been smoking. So, what are the effects of this heavy smoking on the various systems in the body?
So the smoking consists of gaseous matter, and cigarette consists of gaseous particle and particulate matter. In gaseous, most toxic is carbon monoxide. Is carbon monoxide and then particulate nicotine. Nicotine stimulates the adrenal medulla and to release adrenaline, and it also resets the carotid body and increases the heart rate, blood systolic and diastolic blood pressure. Therefore, increasing the oxygen demand and supply. And it also stimulates the autonomic ganglia and it increases the sympathetic tone. And carbon monoxide, it has more oxygen, 200 times more of 200 times more affinity towards the oxygen, towards hemoglobin than oxygen. So it will change the ODC curve to hyperbola and decreases the 2,3 dpg, so decreases the oxygen delivery to the tissues. And hematological system, it increases because of hypoxia. There is polycythemia, increases the increased erythrocytosis and increased risk of thromboembolic phenomenon. And in GAT, it loosens the lower esophageal, lower sphincter.
So, if your patient is chronic hypoxemia because of carbon monoxide inhalation, Will it be shown in the pulse oximetry? If you put a pulse oximeter, will it show they say hypoxia, low saturation because of the hypoxemia?
Sir, conventional SpO2 monitors will show falsely high values, but we have newer things which can show carbon monoxide levels, carbon hemoglobin levels.
There is no knowing. They have found out it long back when the pulse oximeter was introduced itself. They found out that it gives the normal value despite the patient having hypoxemia at the tissue level. As you rightly said, because carbon monoxide has got an affinity of more than 250 times to hemoglobin compared to oxygen. But our normal pulse oximeter with the what is the wavelength of the light that is emitted? Normal pulse oximeter.
It's 440 nanometers and 660 nanometers.
60 and 940s.
660 and 940. Very good. There are two wavelengths of red light, which is emitted 660 and 940, and this cannot differentiate between oxygen and carbon monoxide. Whereas co-oximetry will be able to differentiate between the oxygen and the carbon monoxide. So only co-oximetry can detect. This is a very common question that will be asked if you get a case with a smoking history. So the carbon monoxide inhaled will not be detected by the pulse oximeter which you are using. So if you want to really assess the amount of carbon monoxide, you have to use a co-oximeter which will only be able to tell. So this is a very, very important and often asked question in the examination. Please remember that. The second question they asked about carbon monoxide is how long or how soon you can remove this carbon monoxide if you want to make the blood more amenable to deliver oxygen at the tissue level. As you rightly said, it will shift the ODC curve to the left and make the delivery of oxygen to the tissues much more difficult. So you have to remove this carbon monoxide from the patient's blood before you take them out for surgery. In that case, what are the methods of eliminating this carbon monoxide from the body as soon as possible to make the patient normal before surgery?
So half-life of carbon monoxide. Half-life is at rest is 4 to 6 hours, sir. So we if we wait for 12 hours, there is decrease in the carboxyhemoglobin levels, and with 100% oxygen, it decreases to 40 to 80 minutes. So we can administer 100%
faster. So abstaining from smoking for 12 to 24 hours will eliminate most of that. But if you want it faster, what should you do? You can give him 100% oxygen for some time. Third one is the hyper. You have to give oxygen at a higher pressure. Okay. So if you want a faster elimination, the final and the best method is to give hyperbaric oxygen. Where else do you use hyperbaric oxygen as a therapy apart from carbon monoxide poisoning?
Gram-negative infections.
Excellent, very good. Patients who have gram-negative septicemia or infection in the leg, okay, especially diabetic patients who develop gram-negative septicemia, where anaerobic metabolisms thrive, and you are not able to control them with your routine antibiotic. Hyperbaric therapy is found to be very effective in eliminating this anaerobic infection in the diabetic patient. Okay. Where else the patient will inhale carbon monoxide apart from his own smoking habit? What are the other situations as an anesthesiologist you are likely to meet a patient with a heavy inhalation of carbon monoxide?
Inhalation burns injury.
Very good. In a closed room burns injury. Excellent. So patients who undergo burns injury in a enclosed room like kitchen or within an enclosed room. So where this carbon monoxide inhalation occurs, from what materials you get the carbon monoxide emanation for the patient to inhale?
So plastic.
Garment.
Chemical.
Okay. So nylon, all the synthetic garments, they produce carbon monoxide when there is a burn occurring in a closed room. So that is where patients. So remember these situations. One is smoking causes carbon monoxide inhalation. Another is closed room burns also make the patient, because that may be the killer. The heavy dose of carbon monoxide inhalation in a closed rooms in a burn situation may be the culprit to kill the patient quickly rather than the burns itself. So you must know a little bit more. So you said carbon monoxide when it is absorbed by hemoglobin, it becomes carboxyhemoglobin. What do you call when it is absorbing carbon dioxide?
Carbaminohemoglobin.
Yes, it is carbaminohemoglobin. Okay, so it is not carboxyhemoglobin, it is carbaminohemoglobin. So that is another question they can ask you in the exam to find out the difference between carbon monoxide and carbon dioxide. Carbon dioxide produces carbaminohemoglobin. Carbon monoxide produces carboxyhemoglobin. Okay. Apart from carbon monoxide, what else can the patient inhale? A smoker.
Cyanide person.
Very good. We
Cyanide.
can take some amount of cyanide also. So what is the danger of inhaling the cyanide?
Mitochondrial oxygen utilization is destroyed. It's
What do you call the type of ischemia?
Histotoxic.
Cytotoxic or histotoxic hypoxemia. Okay. So what are the other types of hypoxemia?
Hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and histotoxic hypoxia.
Fantastic. 4 types. So this is how the questions will be asked. Suddenly they will ask you all the basics. Suddenly they will jump to the anatomy. Suddenly they will jump to pharmacology. So you must have a quick thinking to answer these questions within the short time given to you by the examiner. Okay, right. Very good. So you have to. So tell me how you prepare or optimize this patient for this surgery.
So first, smoking cessation for at least 8 weeks. It is an elective procedure, and I will optimize the effort tolerance, increase the exercise capacity, and exercise capacity. I will ask them to practice deep breathing exercise and simple spirometry, and prevent any further exacerbation by giving bronchodilators or steroids. I will optimize the comorbid conditions. If there is any acute infection, I will give them antibiotics prior to surgery, and I will optimize the nutritional status by giving protein-rich foods.
Supposing patient says he brings out yellowish green phlegm. You ask him what is the color of the phlegm. What are all the various colors the phlegm can be?
So white color, white or mucoid.
What is the normal uninfected color of your sputum? Most of us have a cough, and sometimes we also bring out our sputum, isn't it? When will you say a sputum is infected? When will you say a sputum is not infected and normal?
When it is yellowish green, we say it is infected.
Infected. What is the antibiotic that you will suggest before you get a culture report for this patient? The patient says, I get a greenish yellow phlegm.
Amoxicillin.
Amoxicillin alone or along?
Amoxicillin with clavulanic acid for gram.
Clavulanic acid. Okay. So even before you get the culture, you can start the patient on amoxicillin with clavulanic acid. Okay, that is a safe antibiotic. Of course, doing a culture and getting the proper report is very correct for way of treating. But empirically, if you don't have time, you can start the patient on a combination of amoxicillin with clavulanic acid, especially if the patient says the color of the sputum is green yellow. Okay, right. And if he says he is bringing a lot of sputum, do you want any other test apart from the culture sensitivity, microscopic examination? Microscopic examination of the sputum, will it be of help in this case? Or for any patient who is having a cough with sputum history, what is the importance of doing a microscopic examination of the sputum? What can you
Presence of
differentiate?
RBCs can be
RBC,
hemophils.
what is it? The color
Neutrophil.
itself will be reddish. Patient will say, I am bringing out a bloodish sputum. But microscopic, can you find any component of the white cells in the
Eosinophil, aspirin. Eosinophils for
eosinophils? If
asthma.
you find eosinophils, what is your diagnosis? Will it
Sir,
change the
allergic.
diagnosis? It may be
Allergic
asthmatic or
bronchitis.
allergic bronchitis. Okay,
Allergic.
it is not chronic bronchitis, it is allergic bronchitis. Okay? So that also may be sometimes asked because a microscope and CD4 and CD8 cells also will be present. Okay.
Yes, sir.
Right. So these are the things that you want to. So you want to do a smoking cessation. You want to improve the lung function by. Do you want to do insertive spirometry?
Yes, sir.
Yes. It is selective and you have time.
Physiotherapy
It's
and
better to
chest
do.
physiotherapy. Yes, sir.
Right. So what is equal pressure point and what is the effect of the insertive spirometry on equal pressure point?
So normally the equal pressure point will be outside the thoracic cavity in the larger in the trachea. In patients having
Will it go
dynamic
up to the trachea
hyperinflation.
or it will be in the major bronchitis? Your voice is muted.
The cartilaginous bronchus, sir.
Hmm.
Cartilaginous portion in dynamic hyperinflation, this will come down. So there is closure of the airways because of the shifting of the equal pressure point towards the non-cartilaginous part.
Okay.
This incident spirometry will so these patients will purge their lips to overcome this resistance. So incident spirometry also helps in a similar way to overcome this.
So you have to do a good incentive spirometry to improve the lung. Otherwise, the work of breathing will be much more. The patient will get fatigued much faster. Okay, right. Okay, so you have done all this. If the patient says or hides the history that he is a smoker, by examining the patient, can you find out whether he is lying or whether he is telling the truth? What are the signs you will find in a patient who is a heavy smoker, but he denies that he is a smoker? Some patients can tell hide their habits also from you. He may be a heavy drinker, but he will say, no, I never touch alcohol. Like that, he may be a heavy smoker, but when you comes to doctor, he will say, no, I never smoke. Can you examine the patient and find? Huh?
There will be clubbing of the nails.
We'll find that discoloration in the nail or the
Nails.
tip of the finger where if he holds, unless he holds a holder and smokes. If he is a chronic smoker holding the cigarette in his hand, you will find there is a dark brown discoloration and the lips also will be quite dark. Okay, so even if he tells us lie that he is not a smoker, these two things will reveal that he has been a chronic smoker. And of course, his breath also will be smelling of the smoke. And if you ask him to blow, he can find out whether he has smoked or not. Okay, so even if the patient tries to hide history of smoking, can easily find out. It is not very difficult. Okay, right. So these are all the methods by which you find out. Treat the patient and optimize the patient. Now, tell me, how are you going to assess the risk of this patient?
Sir, using bold index spirometry. Sir.
Okay.
If the FEV1 by FVC ratio is less than 0.7 and FEV1 is less than 80, predicted FEV1 is less than 80%, it is graded as mild. It is 50 to 80, 30 to 50, and less than 30. It is classified as mild, moderate, severe, and very severe. And another stratification using board index, BMI, airway obstruction, its effort tolerance, and dyspnea index.
Very good.
Based on that, we can just certify.
Right. Okay. So these are the two index which shall be asked in the exam to find out the risk. Right. So patient optimization is done, risk stratification is done. What are the pre-op instructions you want to give the patient?
Sir, smoking cessation, I will ask the patient to use the inhaler previous night. If the patient is on steroid, I will ask them to take the usual dose of steroid previous day also. And regarding the medication regarding the comorbidities and the NPO for 8 hours, I will ask the patient to bring the inhaler along with them to the OT also. If there is no much CO2 retention, I will give a benzodiazepine to allay the anxiety. And based on the airway, I will arrange the OT whether it is difficult or not. I will position the patient on the OT table. I will attach monitors.
What is your plan of anesthesia? First, always
that-
describe what is your plan of anesthesia before you say, I will bring the patient to OT, attach monitors and all that.
So,
What is
for
your
this
plan of
patient, I will plan
Huh?
general anesthesia with controlled mechanical ventilation, sir.
No, general anesthesia with endotracheal intubation or
Intubation.
supraglottic airway.
Yeah.
Huh?
Yes, sir. So endotracheal intubation, sir, or second generation supraglottic airway.
There is an option. Earlier we were thinking that we should not do laparoscopic procedures with the supraglottic airway because of the risk of aspiration. But after the advent of the second generation supraglottic airway, like Prosil, the iGel and the other things, Baska, where there is a gastric drain possibility, the chances of aspiration have very much reduced. So people have started using second generation supraglottic airway devices also. So I can boldly say in the examination that I will try to, if you are used to endotracheal intubation, you can go ahead and say that. But you can say there is an option to do, because the examiner will ask you, have you ever used Prosil or iGel and in the case of laparoscopy, then you will be in trouble if you have not done that. So it is always safer to say, I am used to endotracheal intubation and anesthetizing the patient with general anesthesia, rather than I have never used or I have seen somebody using supraglottic airway device, but I have no personal experience. That will be a safer answer rather than confidently saying that yes, supraglottic airways also can be used. Unless you have really used and you have an experience, and then you can commit yourself like that. Otherwise, better to say endotracheal intubation. But the next question they will ask you is whether this airway is reactive and more irritable, or it will be a calm airway.
Sir, it is hyper-responsive airway.
It may be a hyperreactive airway. So, intubating this patient, is it advisable? That is why people have started using supraglottic airway devices. But when you have been trained to intubate and practice these patients, anesthetize these patients, how are you going to make the airway tolerate the invasion with an endotracheal tube?
Sir, I will intubate the patient under deep plane of anesthesia. Deep plane of anesthesia with steroid covers.
Now tell me what you are used to doing. Supposing you have this patient and you are qualified and you are the anesthetist for this patient tomorrow. After you go out, you are alone and you are going to take up this patient. How are you going to manage? Tell me the drugs that you want to use to mitigate the chances of hyperreactive airway getting worse.
So first I will pre-oxygenate the patient with 100% oxygen.
Okay.
I will give fentanyl, and I will induce with
what is the
propofol.
contraindication for giving 100% oxygen in a COPD patient? Normally, we are all trained to give 100% oxygen for at least 3 to 5 minutes, or with 4 or 5 capacity breaths. All this teaching has been there. But is there a contraindication to use 100% oxygen in a COPD patient? If so, what type of patient?
So, in hypercardic patients, we give lower concentration of FiO2.
Why?
As
Why?
sir, respiratory stimulant activity is lost with CO2 will stimulate the respiratory center. So
They
it is
are
lost.
dependent on CO2 stimulation. Okay. So what is the name of that syndrome? If the patient is dependent on carbon dioxide for his respiratory effort, with a pot belly, bloated paper per person, and
Pickwickian
always this,
syndrome. Pickwickian.
excellent. It is called a Pickwickian patient, Pickwickian syndrome. You know why that name Pickwickian is given? Why
Yes, sir.
that syndrome is called Pickwickian syndrome? Anjali,
No, sir.
No, sir.
Yalbardi, Vishavardhini, Pratik Shukla. There is a character
No,
by
sir.
an author called Charles Dickens, who wrote a book called
Mickey Mouse.
Pickwickian Papers. Okay, so in that novel, he describes a person who has all the classical features of COPD, in a short statured, bulky, with a big paunch, and always dyspneic. That person is called Pickwick. So the syndrome is named after that character by Charles Dickens, book on Pickwickian papers. So it is called a Pickwickian. So if the patient belongs to that category with a hypercarbia, which is responsible for their respiratory effort, you should avoid giving 100% oxygen. Of course, this is a very, very rare situation you will never come across, but it is better to give only 60 or 80% oxygen, or give by mixed with air, so that you don't give 100% oxygen to this patient. So if you answer very beautifully like this in your examination, then there is a chance they can ask you some extra questions like this to find out whether you are super intelligent or not. Okay, right. So Pickwickian is the syndrome. Okay. So you start with pre-oxygenation, then what do you do?
So I will give midazolam fentanyl and induction agent of choice is propofol. I will avoid
You don't want
thiopentone.
any antisyllagog for this patient?
So
You said
I
only
will
fentanyl?
give glycopyrrolate.
Better, because all these chronic bronchitis patients have a lot of secretions, isn't it?
secretions.
So better to dry up that secretion by giving glycopyrrolate. Can you give atropine instead of glycopyrrolate, which also controls the secretion?
Yes, sir.
Given a
Yes, sir.
choice between glycopyrrolate and atropine, which will you prefer?
So, glycopyrrolate because it does not cross the central nervous system.
Is it because of that effect, or is it because of some other effect on the respiratory system? Atropine makes the secretions more thick and viscid. Okay? So it is very difficult for the patient to cough out in the postoperative period. Whereas glycopyrrolate comparatively will not cause the thickening or viscidity of the secretions. It will suppress the secretions, but it will not make them very thick and hard to expel. So comparatively, glycopyrrolate is better antisyllagogue, more easier for the patient to bring out if there are any little secretions happening. But atropine is very, very powerful in that it will suppress the secretions very well. At the same time, it will make them very thick and viscid for the patient to uh, take extra effort to expel it out. So it will cause terminal collapse here and there, and atelectasis will happen. It will not happen with glycopyrrolate. Okay, so you can use
Okay, sir.
fentanyl with glycopyrrolate for induction. Then
Fentanyl,
propofol you are going to give.
propofol.
Why you want propofol? If you have thiopentone only, and you are made to use thiopentone, what is the risk in that?
Sir, it can cause a bronchospasm in light planes. It will reserve the airway reflexes. So more
Why do you
chance of
want to
bronchospasm.
give low dose to keep the patient in light plane? You said I will keep the patient in deep plane. You give, instead of 3 milligram, you give 5 milligram of thiopentone. Will it not deepen the plane?
It will not suppress the airway reflex.
The respiratory reflex suppression is much better with propofol compared to thiopentone. Okay, so even if you give 5 milligram or 6 or 7 milligram of thiopentone, still the airway can be still more reactive. Whereas with propofol 2 milligram per kg, the suppression of the reflexes is much more efficient and very effective. Okay, so that is the reason why propofol is the preferred agent for induction. What other agents can be used apart from propofol?
So ketamine has the bronchodilating property. So
Very good. It has got a bronchodilator property also. And
but
analgesic
increased the
property.
secretions.
But increases the secretion. So if you give propofol, glycopyrrolate prior to giving ketamine, then that problem can be solved. Okay, right. So these are the induction. Ketomidate. What is the role of ketomidate here?
So adrenocortical suppression can be there. So we will avoid ketamine.
But if the patient has got right heart failure,
We can use that ketamine.
then ketomidate will be. So you have to know, that is the reason why you have to know the function of the right heart in COPD patient. So if there is an established right heart deficiency or dysfunction, it is better to use etomidate rather than propofol or ketamine. Okay, so all the three drugs have to be kept in mind and choose among them depending upon the patient's condition. Okay, right. So you have given the induction agent. How are you going to paralyze and intubate the patient?
So muscle relaxant of choice will be vecuronium. Spoiler vecuronium. I will avoid atropine as it can cause histamine release. And lidocaine can be given to suppress the.
If there is cistatratarium available between vecuronium and cistatratarium, which will you prefer?
The cistatratarium.
Yeah, it is better to choose cistatratarium rather than vecuronium if both are available. Okay, so the other option for vecuronium is cistatratarium. Okay, right. So you give that and then try to intubate. Would you like to do something else before giving the relaxant? Huh? You have given first a fentanyl and glycopyrrolate, then you want to give propofol or you want to give some other drug and then give propofol.
Sir, lignocaine 1.5 mg per
don't forget
kg.
that. That is a very, very efficient method of suppressing the reflex stimulation of the airway. So never forget that, and it will also control what else? What is the other advantage of doing
intubation response? It will decrease the
sympathetic stimulation. Okay, so it is advantages in both ways. It will suppress the airway reflexes and also suppress the sympathetic stimulation through laryngoscopy and intubation. So you must always give the patient lignocaine. Any other advantage of giving lignocaine, which we know all these days only about these two? Is there any other advantage in the present scenario of giving lignocaine?
So along with propofol.
Yeah, along with propofol, what is the, supposing you first lignocaine 1.5 milligram per kg body weight and then wait for about 90 seconds and then give propofol. The two advantages we have discussed is, one is it suppresses the respiratory reflex, other it suppresses the sympathetic response to stimulation. Any other advantages?
Pain because of propofol.
The propofol injection pain can be prevented. Very good. Usually we add only a small volume, 1.5 ml of Elacard to the propofol itself, or give first that and then give the propofol. But giving this large dose of 1.5 milligram per kg body weight, does it have any additional benefit?
So it is also a bronchodilator.
Also bronchodilator. What is opioid-free analgesia? Is lignocaine a component of that?
Yes, sir.
Yeah, nowadays we use lignocaine infusion for post-op pain relief also. Okay, so this IV bolus dose also has got some analgesic property. So it will also help in the initial analgesia for a few minutes till the effect is there. So the third advantage which they have found now is, because lignocaine is added in the armamentarium of drugs used for opioid-free analgesia. So this same effect can be achieved by giving 1 to 1.5 milligram of lignocaine IV before induction will also give some analgesic component also, right? Okay.
Okay,
Then
sir.
after
I will.
the relaxant, before intubation, would you like to do anything to suppress further the reactive airway?
So the pre-injection steroids.
Steroid will suppress. It is an anti-edema measure. It is not. Doesn't have any direct effect to suppress the reflexes.
Sir, laryngotracheal topical anesthesia.
Laryngotracheal topical anesthesia with what?
Exactly.
4%
Lignocane, what percentage? Spray. You can do nowadays. You know,
Yes, sir.
everybody, all of you would have used the 10% spray. Okay, so you can
Yes,
spray
sir.
the vocal cords and the upper trachea before you pass the endotracheal tube. And in my practice, in these cases of COPD or reactive airway, I always put a little bit of xylocaine jelly in the tip of the laryngoscope also, the blade, that folded portion which will lie in the valvular area. I used to apply some lidocaine jelly so that when it contacts the mucosa, it will not stimulate the mucosa also. So that I used to regularly practice, and then spray the vocal cords with 10% or 4% lignocaine spray, and then pass the tube. That will make the patient tolerate the tube without getting the airway stimulated. Okay, so these are all the preparations or the practice that you can do or tell in the examination. Okay, you have successfully intubated the patient with a cupped endotracheal tube. You have connected, and as soon as you take and squeeze the bag is very tight and you are not able to squeeze the bag. What will you do? This is a very common question in this sort of COPD cases in the examination. Induction
So
was
first I
smooth,
will explain the.
relaxant was smooth, your laryngoscopy and intubation was very, very smooth, and you have put in the tube and then you are connected to the circuit, and initially before putting the patient on ventilator, you are trying to ventilate and auscultate the chest, and you find the bag is very tight and you are not able to squeeze the bag. What are the causes?
So I will eliminate first the machine causes and then the patient causes.
Very good.
In machine causes, I will look for circuit kink or any circuit kink or any secretion in the circuit or if there is any
So soon. As soon as you
foreign
start.
body in the
Foreign body.
foreign body
Okay.
in this body.
Tell me more common causes.
So expiratory valve malfunction.
That is all of that you will have checked before starting the case, isn't it?
Yes.
More practical
Or the
reasons for
patient.
that.
Bronchospasm, sir.
That is not machine cause, that is patient cause. He has classified the causes of tight bag into machine causes and patient causes. And in the
Oxygen
machine cause,
flush can be oxygen flush can be reduced.
high flow of gases. That is a very, very common cause of the tight bag. Okay, so you would have kept 10 liters or 12 liters of oxygen for pre-oxygenation and continued with that, and then you would have used some time to fill the bag with oxygen flush also. So supposing there is no obvious heavy sound, how do you know whether it is a extra gas that is flowing or not? Because to keep the bag tight, if you use oxygen flush, you will get that sound, or noise will come.
Yes.
But there is no such noise, and you have reduced the flow also in the flow meter from 12 to say 3 or 4. But still, if the bag is tight, how to find out whether the oxygen flush is still activated or not? Normally, in our anesthesia machines, how does the oxygen flush look like? What type of, is it a button type or it is a lock type?
So a knob which is inside, well inside the
Push
machine.
button type, you know.
Yes.
So once you push and leave it, it should come back to the normal position. So first I inspect that push button. If it is partially struck inside the ring that is holding it, then you will not get that heavy sound of or the flushing sound. But if you keep the circuit near your ears, you will find the gas flow coming. Okay, so that the obvious noise of this oxygen flush sound will not come, but there will be a heavy flow through the partially stuck valve. That is a very common reason why the bag may be tight. Other reasons, of course, you said that maybe a foreign body in the endotracheal tube, kinking, connectors to kinking, all those things are machine. What are the patient causes?
So that can be bronchospasm or pneumothorax. So first, I will disconnect the ventilator circuits from the endotracheal tube and attach to a ambu bag or a vein circuit, and I will ventilate. I will check the bag complaints. If it is okay, then it is machine. Otherwise,
Machine
it is
can
patient
be
cause.
ruled out if you are able to
ruled out.
ventilate with the ambu bag. I mean, if you are not able to ventilate even with the ambu bag, that means the patient is at fault. But if you are able to ventilate with the ambu bag but not with the machine, that means the machine is at fault. You have to change the circuit or change the machine and try to rectify all the problems in that. Okay? So this is a very common question
Yes,
they will
sir.
ask you. Right. After this
Yes, sir.
immediate emergency, if you find that is a bronchospasm, you are able to squeeze the bag and you hear a lot of bronchi when you auscultate, and you make a diagnosis of acute bronchospasm because of irritation. Then what will you do? How do you manage the intraoperative bronchospasm?
So to avoid hypoxia, I will increase the FiO2. I will deepen the plane of anesthesia. I will administer the bronchodilators via the endotracheal tube like
Saying a
salbutamol.
contradictory thing. You say I will increase the FiO2 and I will deepen the plane. How can you do that both? If you increase the oxygen, patient is going to become more light, isn't it?
Yes, sir. Yes, sir.
So how will you deepen the plane by increasing the oxygen level also?
Concentration.
Hmm?
We can't do. I will increase. I will only deepen the plane by
Deepen the
either
plane
taking
with what? With
propofol
more
or
volatile or more intravenous agents? That is the thing that you have to be very careful. So if you want to give higher percentage of oxygen, then you have to go for intravenous mode of deepening the
yes,
plane. You cannot do
yes, sir.
deepening the plane with inhalation agent. Volatiles cannot be increased simultaneously with oxygen. If you increase the volatile percentage, the patient will receive lesser oxygen only. Okay. So if you want to give higher percentage of oxygen, deepen the plane by giving IV propofol. Okay. Start an
Yes, sir.
infusion of propofol to keep the patient unconscious. Cut down or go down on the volatile. Okay. That is the method of
Yes, sir.
deepening the plane. Right. Then
So,
any
I will,
bronchodilator drugs you can use?
yes, sir. Salbutamol sprays can be given.
You can put the spray
And
into the endotracheal tube. There are special injectors which are available. Okay, then
yes, sir. Then we can, if it is not subsiding, we can give magnesium sulfate
okay,
or ketamine, ketamine or aminophylline.
the same chick is the mnemonic. I think I have taught you very early in our discussions. SAME-CHICK, salbutamol, aminophylline,
Salbutamol.
magnesium sulfate, epinephrine, chlorpheniramine molecule, hydrocortisone, equatorium bromide, and
Ipratropium.
8 drugs we have. SAME-CHIK, the same
Yes,
chip.
sir.
Okay, so all these 8 drugs are
Yes, sir.
quite useful in this particular situation, right? So how are you going to maintain the plane of, I mean, during surgery? How are you going to maintain the anesthesia?
Sir,
You
air
have
oxygen.
induced, you have intubated, you have started anesthesia with, say, patient, no bronchospasm, nothing, patient is doing good, and you are, which volatile agent is preferable in these cases?
Sir, halogen is the best bronchodilator, but we are not using, so we can use isoflurane or sevoflurane, sir. Air oxygen,
What is the
isoflurane or
danger of
sevoflurane.
using halogen? Why we are not using halogen nowadays? When you commit like that in halogen, you must be able to answer these questions. Okay. Nowadays, the hospitals don't buy halothane or don't have the vaporizer for halothane at all. But if you commit halothane is a good bronchodilator and that will be the best agent, then you must know why it has been discarded now.
It
Why
is
it is
most
not
arrhythmogenic.
arrhythmogenic. Excellent. So it is when will it is cause arrhythmia? Will it cause it when it is due to endogenous catecholamines or exogenous catecholamines?
Sir, endogenous catecholamines during intubation response.
Normal production of
Intubation.
endogenous catecholamine, halothane is not arrhythmogenic. But if you use epinephrine for, say, surface application or for vasoconstrictor purpose or for any other IV purpose, then halothane will become arrhythmogenic. But in patients who have a chronic stimulation of catecholamines excessive, then they can have arrhythmogenicity in the form of ventricular tachycardia or ventricular fibrillation, and cardiac arrest also have been reported. And that is the reason why halothane, even though it is a very good bronchodilator and has a very pleasant smell, is not preferred nowadays. So which is the drug choice? Which has a very pleasant odor and tolerated very well. Sevoflurane is the drug. Okay. So sevoflurane. Next choice will be isoflurane, which is the newer agent which is not preferred for this reactive airways. Desflurane
Pungent.
is more irritant, and so it should not be used. Okay, right. So this is the choice. Okay. How are you going to? So as soon as the surgeon starts inflating the abdomen with the carbon dioxide, the CO2 starts rising. When you started, it was 45 because the patient is a non-COPD patient. The initial baseline the EtCO2 itself was 45. As soon as the surgeon starts inflating, it goes to 65. What will you do?
Sir, I will adopt lung protective ventilation.
Take away lung protection.
Increase.
Tell me what are the things that you will do in the ventilator?
Sir, tidal volume. Tidal volume. I will decrease the tidal volume and increase the respiratory rate. And I will, if I increase the respiratory rate, I will adjust the IE ratio to 1:3. And I will see that the peak airway pressure is less than 30 and plateau pressure is also less than 25. Less than 25. That's it. And I will see for teeth will be on the list.
So with these maneuvers, you will try to reduce the CO2 and try to bring it back to the baseline level. Okay. So a moderate increase of 50, 55 is not harmful. But if it is going beyond that, it's better that you adjust the ventilator settings to correct this in this situation. Okay. So another common question, of course, for want of time, we don't have to waste too much time on that. What are the cardiovascular effects of carboperitoneum? Quickly mention the points alone.
So, initially, there is a subdiaphragmatic narrowing of the IVC, which will increase the venous return and increase the cardiac output. So, there is increase in blood pressure. And then there is a constriction of the IVC. So, there is decreased venous return and there is decreased cardiac output. So, the heart compensates by increasing the heart rate. And the cardiac contractility also will try to increase in SVR will increase the blood pressure. And there is also decrease in contractility because of pneumoperitoneum CVS.
Right. So as soon as the carboperitoneum is created, initially there will be an increase in CO2 or decrease in CO2, EtCO2.
So a steep increase in CO2 and then there is a plateau phase. After that it remains the same.
Okay. How long does it take to achieve that plateau phase?
So it takes 20 to 30 minutes to achieve the plateau phase.
Very good. And after 30 minutes, supposing after it has become a plateau, it is stabilized at say 45 to 50. Suddenly there is an increase, the EtCO2 goes up to 70. What does it mean?
There is that can be subcutaneous emphysema because of CO2 leak into the mediastinum.
Very good. So these are the points that are commonly asked. So the sudden rise in EtCO2 after stabilization indicates subcutaneous emphysema or a leak through various sources, and that is the reason for the sudden increase in EtCO2. Supposing there is a sudden drop in EtCO2, say from 48
There
to
is
50.
the air embolism. There can be air embolism.
Air embolism, good, very
Yes,
good,
sir.
excellent. So, or there may be a cardiac arrest also. Okay, so that is
Yes,
the
sir.
reason
Yes, sir.
that we have to keep in mind. Excellent, right? So, at the end of the procedure, what are the methods of producing? I mean, providing analgesia for this surgery intraoperatively.
So the intraoperatively intravenous route, or we can give a tab block or a electrospinal block.
What I have taught you earlier. Always when the question on analgesia is asked, what should be your first answer?
Multimodal analgesia.
It should be multimodal analgesia. Please
Multimodal.
remember that and say that as the first answer. Okay, that multimodal includes IV, regional, surface, all these things. Okay, so
Yes.
always start with the multimodal as the first answer.
Modal.
So in this multimodal, what are all the things that you have said? You said we can give IV paracetamol. Can you use NSAIDs? Diclofenac, can you use, which you use routinely?
They will cause. They can cause bronchospasm because of.
Patients with bronchial asthma, it can cause, but the same reaction can happen in chronic obstructive pulmonary disease patients also. So better to avoid NSAIDs and go for the other drugs in the armamentarium of opioid-free analgesia, and all use the regional techniques. So what is the simplest regional technique that can be adopted? Supposing you don't know how to give tab block, you don't know how to give rectus-sheath block, which is the simplest method of giving regional analgesia? Local infiltration to the ports where you made, that can be, you can ask the surgeon. Then finally, at the end of the procedure, installation into the peritoneal cavity and the gallbladder bed, again by the surgeon himself.
Yes, sir.
So if you are not confident and if you have not practiced any regional technique, ask your surgeon to infiltrate the laparoscopic ports right at the beginning itself and also at the end, and also instill intraperitoneally the local anesthetic so that the patient can have some good analgesia post-op. Okay, so 0.25% bupivacaine can be instilled about 20 ml into the peritoneal cavity and the gallbladder bed. Spray it. That is a very good method of providing good analgesia post-op also. Okay, what are the post-op complications in a patient with the COPD undergoing this sort of surgery?
So there can be hypoventilation, hypoxia,
Pulmonary complications.
again bronchospasm.
Again, I have told you a mnemonic in our classes. Where was man born from? Darwin's theory. We are all born from apes or monkeys. So APE, atelectasis, pulmonary
edema
and embolism. These are the three things. Okay. So atelectasis, pulmonary edema, and embolism are the three complications that we have to anticipate in these patients. Okay. Right. So with that, I will just try to show you synopsis or method of answering this.